Welcome to this Enclave News Network presentation, broadcasting live from the MJH studios. Today's discussion will be focused on the treatment of locally advanced lung cancers and evolving treatments for these illnesses. I'm your host, I'm Mark Criss. I'm a medical oncologist and I work at the Memorial Sloan Kettering Cancer Center in New York. Today I'm joined by two friends and colleagues, Dr. Jyoti Patel, Professor of Medicine from the University of Chicago, and Dr. Walter Curran, Professor and Chairman of the Department of Radiation Oncology at the Winship Cancer Institute of Emory University in Atlanta. During the next 60 minutes, we're going to navigate through some of the questions surrounding exactly how we treat patients with locally advanced lung cancers. We'll discuss multidisciplinary care and consider how the availability of immunotherapies will change the treatment landscape going forward. During the last few minutes of the broadcast, we'll answer questions related to this discussion as submitted by the audience, and we invite you to submit questions using the entry field located below this video. In the first group today of issues we're going to talk about, what are the treatment goals for early stage lung cancer? I think that's a really good starting point. Jyoti, would you like to lead that discussion? What are the goals of treatment for early stage cancer? Compare and contrast it to other groups of patients?
Sure. So we will see, unfortunately, still a minority of patients with non-small cell lung cancer who present with the earliest stages of disease, stage 1 and 2. And by and large, those patients are patients who've undergone lung cancer screening or who picked up because of serendipitous testing, and we find that they have a solitary pulmonary nodule. Those patients are treated with curative intent, by and large with surgery, but also sometimes with radiation. About a third of patients present with locally advanced disease, and those patients have regional and mediastinal metastasis. And those patients, again, are treated with curative intent. Again, it's a difficult process because patients already have had some evidence of cancer beyond the lung itself.
Well, you want to answer that?
No, I agree with Jyoti. It's a challenging disease. What's exciting for people to realize, and I think a lot of the lay community, even the medical community outside oncology, doesn't realize the progress we've made in improving the survival of patients with locally advanced disease. The median survival in the trials that we did 2 or 3 decades ago was under a year. Most trials for good performance status patients with locally advanced disease are well in excess of 2 years, even before the trials that are looking at immunotherapy. So the platform has improved. Some of it is not because we have newer therapies, but because I think the oncologists know how to take care of these patients better. They know how to deliver concurrent chemoradiation and manage the side effects. They know how to stage patients better. So the platform from which we're dealing with good performance patients is much better. Those with poorer performance status and comorbidities, the outcome is still pretty tough.
I would add to that in addition to the supportive care, in which we've seen huge gains, there's also some kind of migration because of better staging, right?
Correct.
So
no question.
That we're looking at a different patient population than we might have 2 decades ago.
Yeah, I think one critical difference to the medical oncologist is we do spend the majority of our time treating people with more advanced stages of the illness, for which cure is very rare. Here, cure is not very rare,
right.
And the goal of therapy is cure. I think also when you focus on cure, it changes the dynamic between risk and benefit. I guess the best example, extreme example, would be a bone marrow transplant. Who would ever agree to a bone marrow transplant unless you know that it is a chance for cure? And I think here we have to be really careful to remember that, and that obviously nothing can be done without having a good understanding and agreement with our patients. But more risk is acceptable when there's that chance of cure. I think the other thing worth mentioning, and I've thought about this, about how many people are in this situation. The estimates are somewhere between 40 and 50,000 patients a year are in this stage 3 lung cancer newly diagnosed with stage 3 lung cancer. That's a very, very huge group. I mean, putting it into perspective, all of ovarian cancers is about 25,000 cases. Here, it's a huge number, and we have a chance to cure them.
And if you look at the 5-year survival rates from the 1990 trials, we're talking about 5 to 8% 5-year survival. The concurrent chemoradiation regimens, 12 to 15%. Most of the more recent trials are really in the 25% range. So that's a range not unlike what we saw with localized or limited stage small cell. So now we're dealing with other problems in long-term survivorship of such patients beyond the risk of recurrence of their own disease.
Absolutely.
May I ask each of you, what do you think the biggest challenge is right now for these folks? What kind of a therapy do we need to get more into that cure group?
So I think we are certainly making huge advances in our technology, and so we're delivering better radiation therapy. The integration of our chemotherapy backbone's improved. But probably I would argue that we need to do a better job of risk stratification. So we have really crude numbers or sort of ideas about how patients may fare based on performance status or weight loss or FEV1 or pulmonary reserve and comorbidities prior to enrollment. But even some of those patients we can cure, as you've said. And so knowing when to push the envelope a little bit for our patients, I think really looks, that's to me the challenge in the coming years in understanding either biologic basis of treatment and how to allocate more precise medicine.
Wally?
Yeah, and just to expand even further on that point, there's the risk of toxicity that we have to weigh. I believe there are some patients, and we don't know how to identify them sufficiently, who are probably at a prohibitive risk of treatment-related pneumonitis, for whom you shouldn't be pushing the radiation dose, and you should modify even the time-volume relationships. There's other people who may benefit based on tumor sensitivity from pushing the radiation dose, but we have inadequately identified them to know how to stratify them and identify them for radiation dose escalation. And those are parameters that are being actively studied. My view is we need to study those things more.
And to me, the greatest risk to our patients, though, in this situation is not the failure of the radiation, but the failure of the systemic therapy. I mean, we can discuss the role of radiation in controlling systemic therapy, but the vast majority of failures are not local. They're systemic or sometimes local and systemic, but it's a systemic therapy that we need more than anything else.